So this is the topic is Microsporidia Stromal Keratitis co-infection challenging scenarios.
So I'll start. So very good morning everyone. So I'm Dr. Mukundan Rajarajan. I'll be taking you through 3 cases of microsporidial stromal keratitis which has an unusual presentation and had challenges in management. All 3 patients had co-infection. So starting with the case 1, a 62-year male from Visakhapatnam who is a known case of rheumatoid arthritis on immunomodulatory therapy, present to us with symptoms in the both eye for the 5 days. On examination, he had right eye epithelial defect with ill-defined anterior to midstromal infiltrate that has granular appearance and SPKs. In left eye, 2 focal area of cellularity were noted. Scraping done which showed oval-shaped microsporidia along with gram-negative bacilli. So patient was started on ofloxacin hourly along with voriconazole eye drops hourly. On subsequent follow-up, there was increase in epithelial defect size and infiltrate noted with presence of lot of chemosis. So there was a dilemma whether there is a toxicity of medication versus infection. So repeat scraping was done which revealed only oval-shaped microsporidia. So patient was continued only on topical and systemic voriconazole. On subsequent follow-up, there was consolidation of infiltrate noted with a descemetocele formation for which TA-BCL was done. And in subsequent follow-up, the descemetocele epithelized and the infiltrate healed with dense scarring and vascularization. Moving on to case 2, a 38-year female with complaints of redness, pain in the right eye for the past 1 month. There was no history of any trauma, history of similar episode in the right eye 5 years ago. On examination, vision in the right eye was 20/50 with presence of midstromal edema and infiltrate and KPs on the endothelium. So diagnosis of HSV keratouveitis was made and patient was started on oral acyclovir along with topical steroids. On subsequent follow-up, the midstromal infiltrate was persistent and more denser. So in this visit, we had clinical suspicion of microsporidia. Corneal scraping revealed no organism. Hence, a corneal biopsy was done and a sample was sent for IFA PCR. So scraping revealed oval-shaped microsporidia. So for this patient, we start on PHMB and chlorhexidine eye drops along with systemic oral albendazole. So on subsequent follow-up, she developed epithelial defect with stromal infiltrate appearing more denser. The IFA and PCR came positive for HSV. So a co-infection along with HSV was considered and patient was started on oral antiviral also. So a subsequent follow-up, that infiltrate became more denser and anterior lens capsule involvement was also noted. So plan for therapeutic PK. So 9.5 mm graft was used and intraop lens involvement was noted. And after 2 weeks, patient was started on topical steroids and she is doing well with a best corrected visual acuity of 20/80. So moving on to case 3, a 52-year male with complaints of blurring of vision, redness, pain for the right eye for the past 3 months. He's been on antifungal medication for the past 3 months. On examination, vision was hand movements with presence of large epithelial defect along with infiltrate with a inferior paracentral perforation for which a corneal scraping along with TA-BCL was done. A corneal scraping revealed the presence of oval-shaped microsporidia along with septate hyaline fungal filaments. So diagnosis of microsporidia as fungus co-infection was made and patient was started on antifungal and eventually ended up in therapeutic PK in view of deep microsporidial infection. So corneal button grew aspergillus flavus. There was no recurrence in 2 weeks and patient was started on topical steroids. The half corneal button also showed presence of fungal filaments along with the oval-shaped microsporidial spores. They are better appreciated in the image C and D. Image C is a GMS stain where a fungal hyphae are seen as a black thin hyphae, whereas image D is a Quignon stain where a bright red oval microsporidial spores are noted. Thus, in conclusion, microsporidial stromal keratitis is a rare entity. Literature search, we found very few case reports of co-infection with microsporidial stromal keratitis. Most of them were associated with viral and bacterial co-infection. According to our knowledge, there is no case of microsporidial stromal and fungal co-infection reported in the literature.